I'm sorry, I actually stopped the stream. I did not mean to. I'm back now. Can you folks hear me? Holy cow. Technical issues on Roddenberry. I actually clicked on the stop streaming button. Much better now, right? We got it. You can hear me? Go ahead and check in and let me know you got me. Okay. I can't keep my fingers off of the buttons here. Okay. Always takes me a minute. I figured the last one, I was hoping the last broadcast would go smoothly and perfectly, but of course not. Okay. So let's go ahead and get this party started. Okay, let's go to the PowerPoint. So today we're going to talk a little bit about biological treatments in general. We're going to talk about altering transmitter function, and then we're going to talk about treating depression, schizophrenia, and other biological treatments. So if you remember yesterday, I talked about psychotherapy. I suggested two things. Number one, I suggested to you that there are two basic kinds of treatments. There are biological treatments that are based on chapter 2 and what we know about the anatomy and physiology of the brain. And the second class of treatments are what we call talk therapy or psychotherapy, which is where we try to use other parts of the textbook, maybe what we know about behaviorism, maybe what we know about emotional functioning, maybe what we know about personality, and we try to talk through the problems. Because if you'll remember, what I suggested to you last week was we really don't know biologically what's going on in the brain that causes a lot of psychological problems. So there are sort of this two-pronged approach: psychotherapy, talk therapy, and we use biological therapy because we don't always know exactly what brain function causing the psychological disorder. In fact, it's probably a combination of environment and physiology as well. So we talked about talk therapy yesterday. If you'll remember, I talked about psychodynamic theory, talking about your problems and your conflicts. I talked about behavioral approaches. And then I talked about improving your habits of thinking in cognitive behavioral therapy. So that was sort of yesterday's treatment approach. Today we're going to talk a little bit about biological treatments, which are capitalized on what we know about brain function. Now, treatments for psychological disorders in 1900 was mostly biological and reflected no understanding of how the brain works. So they used stuff like warm water baths. They would wrap you in wet towels. They would put you in sensory deprivation chambers. They used to they used to inject people with insulin to cause them to go into a shock. They would use electroshock therapy to cause people to have a seizures. They would do all of these different things without any idea at all of what was happening in the brain. It was scary, it was dangerous, it was barbaric. Okay? Newer forms of biological treatment are less scary, less barbaric, but are still based, I hate to say this, on an incomplete understanding of what's going on in the nervous system. But these newer forms of biological treatments, which are effective, are based on some general insights about brain functioning. Okay, now here's what we know about the brain. We know that brains secrete and respond to chemicals uh, called neurotransmitters. We do know that. We know that there are chemicals being released in the brain and used in the brain to help our functioning. We know that brains generate electricity and that different parts of the brain respond to electricity. So we know brains use chemicals and we know brains use electricity. And we also know that the brain is divided into specific areas, which I suggested to you we'll call brain modules. And we know that when these modules quit working, as in Broca's area, remember, or as in HM in the hippocampus, we know when brain areas malfunction or are damaged, specific abilities are lost. So we know these three broad properties about brains. We know these things for certain. All the details I would suggest to you are still sometimes a mystery, but we do know these three basic processes of brains. So, what are our general types of biological therapies? Well, we have drug therapies that alter the function of these chemicals. We now know that we can use electromagnetic energy in the form of magnets put outside the head, and also sticking wires and into specific brain areas. We know that we can use electromagnetic therapies to alter the function of brain activity. And we also know we have the ability to go in and remove or alter parts of the brain, so psychosurgery. So we do have these three basic insights on how the brain works, and we have these three therapies that are based upon our general knowledge of the brain. And the type of treatment will change with the nature of the psychological disorder. Each type of treatment has advantages and disadvantages. So if you look from left to right at the bottom of the screen, you see the neurotransmitter functioning, and you see the little red molecules being diffused in the synapse between the dendrite and the terminal button. You see next to that a little baby with an EEG on, measuring the electrical output of different parts of their brain. And you look directly beneath me and you'll see a coronal cut of a brain identifying all the different areas of the brain, these little spots in the brain. You notice in the bottom on either side of that triangle, two little dark spots, the substantia nigra. That's where neurotransmitters, dopamine in your brain is created. And those little parts get damaged, and that's why Parkinson's starts. So we know these three general properties, and we have these three general treatments based on our knowledge of these properties of the brain. Now let's talk a little bit about drug therapy for a couple of minutes. Actually, that's probably what I'm going to spend more time talking on, because if I'm being honest, that's the type of therapy that you are most likely to get. Surgery for electrical stimulation is expensive, has risks, and is only useful in treating sort of basal ganglia related disorders. So it's not very common. Psychosurgery, going into the brain and cutting out pieces of the brain, really is expensive, dangerous, and there are always serious side effects with psychosurgery. So 95% of the time, what's going to happen is you are going to be given drug therapy of some sort. And the idea here is to alter the function of the neurotransmitters. So if you look right below me, you see the prototypical picture of a synapse. You'll see the terminal button at the top, and you'll see right there the synaptic vesicle is releasing little red neurotransmitter molecules that diffuse across the synapse and fit into the protein locks on the postsynaptic dendrite and send messages. And what we know is that these neurotransmitters acting in different parts of the brain cause us to experience different things. They cause us to experience emotions, motivations. They make our body move, and they make our body not move. So we know that these neurotransmitters are very important for our psychological functioning. Now, there are two ways we can affect these neurotransmitters. We can use what are known as agonists, and we can use antagonists. An agonist is any drug that magnifies the effect of a neurotransmitter. We know that serotonin is related to mood, and we know that drugs that magnify, that multiply the effect of serotonin tend to cause people to have a better mood. And so we know we give people serotonin agonists to improve their mood, to fight people's depression. Okay. On the other hand, we sometimes give people drugs that work against the impact of a neurotransmitter. Now, Dopamine is responsible for helping coordinate smooth motor movements. And if you don't have enough of that, you may have Parkinson's disease. But we also believe that too much dopamine is associated with the hallucinations and delusions that are a part of schizophrenia. So, what we do is we give people drugs that work against the neurotransmitter dopamine in order to cure them of their hallucinations and delusions. Okay, now keep in mind when we give these people drugs like Seroquel, like Risperidone, like Xanax, these drugs diffuse through the brain barrier and they work systemically. What do you mean, Chris, when you say systemically? They work all over the brain. They don't just work in the neurotransmitter area that we want them to work in. They work all across the brain. So maybe dopamine in delusions only works in this part of the brain. And I'm not even going to say parts of the brain because we don't know, and I don't want to give you the idea that I know. But let's say that dopamine malfunctioning right here is what causes schizophrenia. Well, I can't just give you dopamine here. I give you dopamine and it courses all through your body. And maybe dopamine over here takes care of another function. So as we give you dopamine in different areas in your brain, it's going to affect all these different dopamine areas. The same thing with serotonin. Maybe this is your serotonin area for depression. When you take that pill, the serotonin is going to work there, but it's also going to work all over your brain. So these neurotransmitters work systematically. They're a very big, broad hammer that are used to fix a problem which may be occurring in one teeny tiny place. Now, any of these drugs that can pass through the blood brain barrier and get into your brain and alter your functioning are called psychotropic drugs. You know what? Alcohol is a psychotropic drug. Marijuana is a psychotropic drug. MDMA, methamphetamine, cocaine, these are all psychotropic drugs. They are small enough molecules that they can penetrate the blood brain barrier and they cause effects at our synaptic gaps. All right. And just like those illegal psychotropic drugs, there are legal psychotropic drugs that we use to treat psychological disorders. So we have tranquilizers like Xanax, which help people who are suffering from anxiety. You might take selective serotonin reuptake inhibitors, SSRIs, tricyclics, or MAO inhibitors for depression. We have antipsychotics, old school psychotics like Haldol and Thorazine, which are called your typical psychotics. And then we have a newer brand of psychotics, the anti like Risperidol and Risperidone, which are and Seroquel, which are used to treat the psychotic effects associated with schizophrenia. We do have a mood stabilizer, lithium, which is used for people with bipolar disorders. And we do have stimulants, which help people who have attention and focus problems. Any questions so far? And remember, these psychotropic drugs mediate, they're either agonist or moderate, they're antagonist, the functions of neurotransmitters. Now, efficacy is judged based on behavioral effects. They really don't know what's going on when they give you this drug physiologically. Instead, they are based on their behavioral effect. The doctor will give you the drug and say, do you feel happier? If you say no, the doctor will then give you another drug and say, do you feel happier? And they're really just kind of shooting in the dark, giving you drugs to see how they affect your behavior. What's going on in your brain? Your doctor does not know. Okay? Now, here's the deal neurotransmitters work in different parts of the brain and are responsible for different things. So some psychotropic drugs are going to be used for more than one disorder. So you might find yourself maybe you're depressed and you're taking a drug that I tell you is useful for uh, as an antipsychotic. That doesn't mean that your doctor thinks you um, are schizophrenic or have a psychotic disorder. So there are some disorders that are used for psychosis that are the same as are used for attention disorders. So some drugs will be used for more than one disorder. And since neurotransmitters effects occur and vary in different parts of the brain, all psychotropic drugs are going to have unintended and potentially disrupting effects on the function of other brain areas or side effects, so to speak. Okay? So this is sort of what you have to keep in mind. We don't 100% know what's going on. So take your drugs in this lecture with a grain of salt. Any questions so far? Okay. Now, so drug treatment, let's talk briefly about bipolar disorder and sort of give you an idea of what we're doing. Bipolar usually involves these mood swings which disrupt your functioning. It's okay to be happy and a little bit sad, but sometimes people's moods swing so extremely and so quickly that it causes these people personal distress. It ruins their job functioning and it makes other people unhappy, and it seems a little odd. Remember the definition I gave you for the definition of a psychological disorder? People who have these extreme mood swings are sometimes diagnosed as having bipolar disorder, and they're given drugs that stabilize these mood swings. The most common one is lithium bromide. So it's a lithium salt. Now, Iscalith is the trade name, that you might find that advertisers use. But they'll usually get mood stabilizing drugs called lithium and anticonvulsants. Depakote is a famous one. So what they're going to do is they're going to give you this drug that sort of blunts your emotional mood swings. It blunts your emotional mood swings, makes them not get as big one way or the other. Okay? Now, if you remember last week, I talked to you about whether or not you would be diagnosed with type 1 bipolar or type 2 bipolar. And I suggested to you if you were type 1 bipolar, that meant that your mood swings mainly featured more mania than depression. So you were more up than down. Or if you're a type 2 bipolar, that meant that your downs were more severe than your ups. And so what they do is they add another medicine on top of that to control the behavioral problem that is the strongest. So if you're a type 1 bipolar, that means you're going to have your manic episodes. And here's the crazy thing, when people get manic, they sometimes start having thoughts that are a little unrealistic, a little grandiose. They start having, if you will, maybe delusional type of beliefs. And so what we do is we give them an antipsychotic, which helps contain the grandiosity of those emotional events that they have. And so they'll give you Seroquel, which is an antipsychotic. Now, does that mean you have schizophrenia? Absolutely not. They just know that along with blunting the severity of your moods, we want to give you drugs that are going to control those expansive thoughts that often are associated with with um with the mania, the periods of mania. If, on the other hand, you have type 2 bipolar, what they're that means your depressed episodes are the strongest and the most severe. They're going to give you the antidepressant uh, in order to help you, in order to help the sadness associated with the depressed periods. But remember, be careful using these drugs because they can be very toxic. Now, I want to tell you in general, lithium is dangerous. The therapeutic dose is close to the toxic dose. When we evaluate the danger of drugs, and when they tell you that, let's say, heroin is more dangerous than alcohol and alcohol is more dangerous than marijuana, what they're doing is they're telling you about the difference between the therapeutic dose and its relationship to the toxic dose. Okay, drugs that are not dangerous have a therapeutic dose which is much smaller than the toxic dose. So you smoke one joint and it gets you high, but there's no amount of dope you can really smoke, marijuana you can smoke to kill you. On the other hand, with alcohol, 3 beers will get you drunk, but maybe 20 beers is toxic and cause you to die. So it's within the realm of possibility to drink enough alcohol to harm yourself. On the other hand, with heroin, what makes heroin such a dangerous drug is the therapeutic dose is just a little less than the dose that will kill you. So you have to be very careful with the amount of heroin. The addict is very careful with the amount of heroin they take because it's very easy to overdose themselves and kill themselves. Same thing with lithium. The amount of lithium that helps the mood swings is fairly close to the amount of lithium that is very dangerous for you. So, what your doctor is going to do is they are going to creep up the lithium dose until you start reporting that your mood swings are getting better. So, they're going to start you with too little lithium and they're going to have you come back and they're going to gradually increase your dose until you say, yes, my mood swings are getting better. So lithium can be potentially dangerous. Now, here's the deal. Depression is a huge problem in adolescence. I don't know if you know this. 8% of 12 to 17-year-olds have had a major depressive episode. And we also know that suicide is the second leading cause of death in adolescence. So suicide and depression is a pretty big problem in the teenage years. Okay, so and you'll notice that females are much more likely to be depressed than are males. If you'll remember from last week, I suggested to you that there are gender differences between internalizing and externalizing disorders. Depression as an internalizing disorder, one that you feel inside and you don't act out, is more common in females, and depression is an internalizing disorder. So it's more common in females than it is in males. Okay, so this is an important problem that we want to treat. So we typically treat depression with two classes of drugs, MAOIs and SSRIs. Both of these drugs work to magnify the amount of serotonin in your brain. I don't think this is going to be on the test, but an SSRI is a selective serotonin reuptake inhibitor. If you look at all those words, selective serotonin reuptake inhibitor, what it does is it prevents the serotonin that is released from your terminal buttons from being sucked back into those terminal buttons. So basically, it causes the serotonin in your brain to stay there a little longer and to send more messages to the postsynaptic neurons. So it artificially magnifies the amount of serotonin in your brain. Now, there's this other stuff called monoamine oxidase. It's kind of like the garbage man that comes by and picks up stray serotonin. It cleans it out of your neurotransmitters. So not only are neurotransmitters sucked back up into the terminal button of the presynaptic neuron, but they're also picked up by garbage men that just sort of clean out the synapse. Well, MAOIs are monoamine oxidase inhibitors. So what this drug does is it inhibits the garbage man that cleans up the neurotransmitter serotonin. Again, what that does functionally is that artificially increases the amount of serotonin that is in your synapse. So it increases the amount of serotonin in your brain. Both of these drugs work neurologically to increase the amount of serotonin in your brain. Now, here's the deal. Antidepressant use is associated with increased suicidal ideation, which is thinking about suicide. Now, the evidence doesn't necessarily show that it causes teenagers to be more likely to engage in suicide, but it does. We do know that antidepressant use typically increases the thoughts of suicide in teenagers. Now, whether or not it actually causes them to kill themselves is nobody can say that with a great deal of certainty. However, we do know that one of the first steps along the path to committing suicide is to think about it and to make plans for it. So, one of the things that scares doctors is when you give these kids these antidepressants, they will start thinking specifically and talking about suicide. So, if you have a teenager that you are putting on an antidepressant medicine, your doctor is really going to be concerned about this uptick in suicidal ideation that occurs. Okay? Now, if you look over here, this chart right here looks at the data from the TAD study, which compared the effect of cognitive behavioral therapy and different antidepressants in treating people's mood disorders. Now, if you look over on the y-axis, it says improvement percentage. Basically, this improvement is not a physiological measure. It's a self-report. Remember, we talked about self-report and projective tests. This is a self-report of one's mood. So this is the doctor saying, how do you feel today? And your report telling me how happy you are. See how broad and vague that measure of effectiveness is? Imagine you break your arm and I come in, and the way I tell you if you are cured or not is I say, hey, how does your arm feel today? Does it hurt? Does it not hurt? That's pretty broad, and you probably wouldn't like that as a medical diagnosis. But unfortunately, that's how we have to do it in the field of clinical psychology. So it's your self report of improvement. Okay. And what you're going to notice there in the placebo is that some people with no medicine at all, some people with no medicine at all are going to report some degree of improvement in in their symptoms. Now, the green bars represent improvement after 12 weeks. The blue bars represent improvement after 36 weeks. Now, what we're comparing is cognitive behavioral therapy, which I suggested to you on Tuesday, which I talked a little bit about Tuesday, and then uh, and then Prozac is a typical antipsychotic that is used. So what we have here is we're comparing three different treatment paths. Some people were only given cognitive behavioral therapy, some people were given only drug therapy, and some people were given a combination of both drug therapy and talk therapy. Okay? And what you're going to notice is that the Prozac and the cognitive, that really you're going to get effects a little bit quicker if you get the combined therapy. But cognitive behavioral therapy is pretty effective at treating people's depression. On the other hand, Prozac also is very effective at treating people's depression. And really, you can combine them together, and what you're going to get are just quicker effects, but really, there's going to be sort of a ceiling of improvement. So, all three of these treatment methods work, but it seems like the combined method probably gets you quicker results, right? But, cognitive behavioral therapy is also effective if you give it enough time. So some doctors prefer the drug-free method. The only problem is it requires more visits and more money. And as a typical rule, your insurance company is not going to be interested in spending more money and more time. But you know what? Drug-free therapies do work. Okay? Now, let's talk a little bit about using dopamine inhibiting drugs. There's this thing called the dopamine hypothesis. Is it based on any physiological evidence? Not really. We just know that if you give people drugs that impair the functioning of dopamine, their hallucinations and their delusions get better, and they become a little more organized in their thinking and talking. So, typically, what we tend to talk about in schizophrenia are positive symptoms and negative symptoms. Positive symptoms are sort of things that are added on. You begin to have delusions. You begin to have hallucinations, and we typically talk about negative symptoms, which is the amotivation and the loss of emotional functioning. Those are sort of the negative symptoms of schizophrenia. Okay. And so what you're going to find is that the typical antipsychotics that they give you are really good at decreasing the positive symptoms, the delusions and hallucinations associated with schizophrenia. In fact, the drug Thorazine, when it was invented in the 50s, was hailed as a wonder drug because before then there was absolutely no way people with schizophrenia would be able to live outside of an institution. Because if you saw Gerald, if you can't control his beliefs and his emotions and his thoughts, Gerald is going to hurt himself or somebody else. So when Haldol and Thorazine were invented in the 50s, it led to the mass deinstitutionalization of people in America. It was seen as a watershed moment in in psychiatric treatment. And in fact, I would say it was this incredible success in the 50s that really created this engine for creating psychotropic drugs. All right, now here's the deal. Unfortunately, there are some problems associated uh, with using the typical antipsychotics. They're great for reducing the positive symptoms. However, they are not as good with the negative symptoms. And more importantly, they have this side effect, this involuntary ticking that usually occurs in the face and a lot of times in the lips like that, which is known as tardive dyskinesia. In fact, if you're watching TV, you will occasionally see an advertisement talking about this particular side effect, which does occur with some psychotropic drugs. Now, the deal with in tardive dyskinesia is that when you get this, when you start to get this effect, stopping the drug may not cause the facial tics to go away. All right. Now, sometimes they do go away, but stopping the drug doesn't necessarily make this face ticking go away. So, that's a big side effect associated with the older class of, of antipsychotics, or what we call the typical antipsychotics. Okay. However, now we use these things called they've developed a second class of antipsychotics called atypical uh, antipsychotics. Examples are risperidol and Seroquel. Now, these drugs are less likely to result in tardive dyskinesia, and there is some evidence to suggest that they may reduce the negative symptoms. If you look over at the graphs I have over on this screen here, you'll notice that these are, again, behavioral reports of symptoms. This is nothing physiological that we know. These are just behavioral reports. And people report less symptoms when they take less negative symptoms when they take these atypical antipsychotics. So we have drugs that affect the level of dopamine in your brain. And by decreasing the functioning of the dopamine in your brain, inhibiting the function of dopamine in your brain, these drugs tend to get rid of or minimize the delusions, hallucinations, and disorganization that goes along with schizophrenia. However, there is a side effect that you have to be aware of when you're taking these antipsychotic drugs. Actually, I've seen these advertisements used within the context of other behavioral disorders too. So just because you're not being treated for for schizophrenia doesn't mean you can't be taking a drug which causes tardive dyskinesia. Okay. Now, this is not going to be on the test, but I just want you to kind of know. I want you to be directed in your book to table 15, which sort of gives you an overview of the the psychotropic drugs that you have probably been given by your clinical psychologist. And there are really five broad classes of drugs. We know there are drugs that decrease people's the anxiety levels. Okay. Um, and these drugs, and these sort of work at the level of your neurotransmitter GABA. We know there are a class of drugs that tend to elevate people's moods. They probably work on serotonin. Okay. There are these things called mood stabilizing drugs that sort of minimize the swings between positive and negative emotions. There are another class of drugs that we know tend to get rid of people's hallucinations and delusions, and we think they're related to dopamine functioning. And then we know that there's a class of drugs that energize the frontal lobe of people, the acetylcholine and the noradrenaline synaptors in the front part of the temporal lobe, and these drugs work as stimulants to help people who have focus problems. So there are five broad sort of effects that we know that psychotropic drugs have. There are those that make you more relaxed, there are those that make your mood happier, there are those that slow down your mood swings, there are those that make your delusions and hallucinations go away, and there are those that increase your focus. Now, so those are the five broad effects that we know that these psychotropic drugs have. And if you'll notice over there on the far right corner are the brand names that you can take a look at to see if you recognize any of these particular drugs. You probably have all heard of Valium, Xanax, or Ativan. I'm sure some of you have probably heard of Prozac, Paxil, Zoloft, right? Maybe you've heard of Chlorazil, Risperdal, or Zeraquil. I'm sure everybody's heard of Ritalin and Adderall. And these are all trade names. These are the brand names by which they sell these neurotransmitter impacting drugs. Now, drug therapies capitalize on our understanding of neurotransmitter functioning. However, there are other therapies that capitalize on our ability to locate and alter the functioning of brain area. Okay, brain commissurotomy. So one thing they can do, one of the earliest treatments was this thing known as a commissurotomy. Some people have seizures. Seizures are just this random electrical activity. Think of it as a short circuit that starts in one area of your brain and spreads all over your brain. And people who have seizures can have mild seizures from where they close their eyes for a second and you don't even know they've had a seizure, to those people who have the grand mal seizures where they fall out on the ground and start shaking and kicking around, and it really is disrupting. There are some people who have seizures that are so severe and are uncontrollable that medicine won't help and other behavioral means won't help them. And so what they do is one of the earliest psychosurgeries that was done was they pulled people's brain, separated out, and they cut the corpus callosum in half so that the electrical activity can't go from one side of the brain to the other. This is known as a commissurotomy. A commissurotomy. Now, back in the whole old days, they would cut the whole the whole corpus callosum in half, and that would have some severe side effects. Now they cut most of the they've found that you can leave part of the corpus callosum together, and you don't get the side effects, but you still get the relief from the seizure surgery. So, a commissurotomy was the first real attempt at brain surgery that's still used. There's this thing called the frontal lobotomy, which we'll talk about tonight, and and we'll talk about tonight in webinar if you come to it. But really, the one that you might see used now is the commissurotomy. Now, there's also electrical convulsive therapy. And basically, what they do is they use electricity to cause a short seizure. Now, this was also used, just like a frontal lobotomy, as a means of behavioral control back in the 30s and 40s and early 50s before we knew any better. And it is not used, it fell out of favor in the 50s and 60s and was not used as much. However, it's made a comeback. It is still kind of controversial, but there are some people who suffer from really, really severe depression that doesn't respond to medicine. And what they found is that some of these people report a quick and significant increase in the positivity of their mood after going through ECT or electroconvulsive therapy. And if you look down in the bottom left-hand corner, you'll notice that this lady is getting ready to go through electroconvulsive therapy. She's got the big mouthpiece in so she doesn't bite her tongue or hurt herself. And basically, some people would hurt themselves because you have such a strong seizure, people could hurt muscles or damage their back. Now, what they do is they give you a muscle relaxer so that you don't kick around as much when you get the electroconvulsive therapy. But they're getting ready to pass, see that little thing that they've got? They're getting ready to pass some electrical voltage into her brain to cause a seizure. Now, unfortunately, there's a little bit of short term memory loss that occurs when you have electroconvulsive therapy. And that's one of the things that critics point out to when they don't like the ECT. Your doctor's probably not going to talk about the use of ECT for treating depression. As I said, it has such a bad history that it is still fairly controversial. All right. Now, there is also a thing called transcranial magnetic stimulation. And if you look at the picture sort of right beside me, what we can do is without putting electrodes on your brain, they can actually take magnets and put them over different parts of your brain. And when you put this magnet over a part of the brain, it sort of disrupts the functioning of that area for just a second. And what they do is they don't do it for long. In fact, I've got a video that I can show you tonight. Pop, pop, pop. They do it and it lasts just a second. And they may do it multiple times. And transcranial magnetic stimulation has sometimes been seen as being useful for treating people with depression. Now, if you look at the picture right underneath transcranial magnetic depression, you'll see what's known as deep brain stimulation. So if you've ever heard of having a pacemaker for your heart, an electrical wire that stimulates your brain, they have the same concept for your basal ganglia, these circle of structures in the middle of your brain that helps modulate your behavior. People with Parkinson's, Tourette's, OCD, and dystonia have trouble with controlling their body parts. And what they'll do with deep brain stimulation is they take a wire and they surgically implant it deep down in the middle of your brain into one of the structures in your basal ganglia. They run a wire that runs underneath your skin, and they implant a pacemaker underneath your skin right here on your chest, and they give you a little remote, and they use that remote to turn on your little pacemaker. And what that thing will do is it will send electrical stimulation to that part of your brain which is not active in the basal ganglia. And what you'll find is that the effects of deep brain stimulation on Parkinson's happens almost immediately. And deep brain stimulation does help people who have behavioral tics associated with Parkinson's, Tourette's, OCD, and the disorder called dystonia. Okay. Well, that's all I have to say about the biological treatments for psychological disorders. This represents the last lecture of the semester. Don't forget, we are having a review tomorrow morning at 9 a.m. for the final exam. Review's been moved up a day, and the exam will begin tomorrow and run through Sunday. Does anyone have any questions for me before I log off? It's been great getting to know all of you. Yanan, Amber, AK, thank all of you for coming this semester. You have been a great and dedicated group of students, and I have really enjoyed interacting with you. Um, I hope you have a great day. Enjoy your Wednesday afternoon. If you have an interest, please come to the webinar tonight at, let's see, what are we, 7 o'clock. And otherwise, I will see you tomorrow morning for the final exam room. Oh, hi, Christine. Didn't see you. Otherwise, I will see you tomorrow. So have a great day, and I look forward to seeing you soon. Bye.